Dr. Bailey. How are you doing today?
Not too well. I've been feeling really tired lately, and it's been really hard to breathe. My eyes also feel really itchy and puffy, and I just overall don't feel as well as I normally do.
Okay, I know that you're an Olympic swimmer, so I know that's not like you to be feeling like this. Well, let me go ahead and check you out a little bit and see what's going on. First, I'll start with checking your eyes. Yeah, they do look very swollen and puffy. Okay. And I will also check your lymph nodes really quick. Yeah, they're very swollen. Right. Let me check your heart rate. Okay. Let me check your lungs. Can you breathe in and out? Okay. Okay. Thank you. Right. And I will just end it by taking your blood pressure. Rest your arm here. Okay, your blood pressure is 145/80. So that's really high, Colleen. So we're really gonna have to admit you at this point.
Okay. If you think that's what's best.
Okay, and I'm also going to run some additional tests.
Okay, sounds good. What kind of tests do you think? Like MRI?
Probably an MRI, a CAT scan, and also some blood work.
Okay.
All right.
Thank you, Dr. Bailey.
You're welcome.
Dr. Shepard.
Hey, Dr. Shepard. This is Dr. Bailey from Duke. How are you doing?
Great, what's going on?
I'm calling because we actually got the strangest case at my hospital, and we are recruiting some of our colleagues from MBS. Our patient ended up dying from cardiac arrest before being admitted, so we need you to help us in diagnosing her. We have already collected the organs and gathered histological samples. We have also run a few MRIs and gathered her medical history. I do want to inform you that Dr. Weber will be participating as part of the web conference to discuss the histological findings.
Oh, come on, not that guy. Anyways, count me in, I'll be there.
Thanks, Dr. Shepard. I look forward to seeing you at the conference.
I look forward to seeing you too, Dr. Bailey. Bye. Hello, I'm Dr. Derek Shepard. I'm a neurologist and an attending physician at the Cleveland Clinic. I obtained my medical degree from Columbia University College of Physicians and Surgeons, and I also obtained my master's in biomedical sciences at Duke University. I wanted to thank my colleagues for reaching out to me about this interesting case, and I'm looking forward to this mortality conference with all of you. Well, maybe some of you. Anyways, let's move on. So first, I wanted to show you what a normal pituitary gland looked like on a histological section. And then in these later slides, we will look at some of the histopathological sections of our patient's brain, as well as the eye and conjunctiva. So like I said, we'll start here with the normal pituitary. So if we look here at this left image, we can see the entire pituitary gland. We have separated the anterior pituitary as well as the posterior pituitary, represented by AP and PP. You can easily tell the difference between the two in this H&E stain because the anterior pituitary stains much darker than the posterior pituitary. Some other notable features here are the presence of the capsule around the gland, as we see here, and the capsule follows around the pituitary gland. And then we also see the pars intermedia, which is the section that splits both the anterior and the posterior pituitary here. Now, if we look at the right image, I've zoomed in on this section, box section right here. And then we can start to see the cells that make up the anterior pituitary specifically. So some of the notable cells that we see are these dark red staining cells. So they're dark red cytoplasms. These are eosinophils. The cells with the pale staining nuclei with the dark purple granules within their cytoplasm represent the basophils here. So we can see a pale staining nuclei and a dark purple cytoplasm. And then lastly, we see, again, pale staining cytoplasm, but almost translucent looking with a dark purple nuclei. These are the chromophobes. And then, of course, we have blood capillaries as well, as we can see here with the red blood cells within them. Now, if we look over to our patients, this is our patient's anterior pituitary. Again, we see cells such as the chromophobes, that almost translucent looking cell with very, very light pale staining cytoplasm. We see the dark purple cytoplasm, pale staining nuclei. These are the basophils. And then we see these dark red staining cytoplasm with the dark staining nuclei. These are the eosinophils. And then what we didn't see in the normal section that we do see in our patient section is this large mass here of cells. This is what we've come to find out is a granuloma. This granuloma is surrounded by these mononuclear cells or lymphocytes. So the dark purple staining lymphocytes. And then within the granuloma, we see something called a multinucleated giant cell. We see a couple of them here. And these are some key characteristics of these granulomas. Now, keep in mind that this granuloma is non-caseating. It is a non-necrotizing granuloma. So it is just growing here within the tissue. So these granulomas within the pituitary gland might explain some of our patient's symptoms, such as fatigue and unexplained weight loss. Additionally, the patient's blurry vision could be explained by the granuloma due to the increase in size of the pituitary gland. And then that increase in size could make the pituitary gland swell and push up against the optic chiasm. And then these could be caused by diseases such as Takayasu's disease or Kogan syndrome. All right, next we'll move on to a normal cerebellum. So if we look here in this top left image, we see the normal cerebellum. Some notable features of the normal cerebellum is that it has a highly folded surface, and then it is split into the cortex or the gray matter. And then this middle area, denoted by the W, is the white matter. So if we look over, this is just a section taken from right here. So looking over on this right image, we can see that the cortex is split into two different layers. We have the molecular layer and then the granular layer. And then again, we see this W denoting the white matter. So now if we zoom in on a little section here, that is this bottom image, we can again see the molecular layer, the granular layer, as well as the white matter. And then in between the molecular layer and the granular layer are these Purkinje cells. And these are these neuronal cell bodies. And these cells are definitively telling us that we are within a human cerebellum here. And one cool part about this image is that we can actually see, if we zoom in even more, we can see these dendritic dendritic branches coming from these cell bodies of these Purkinje cells, and the axons of these cells would be coursing through the granular layer into the white matter, but we can't see that on this stain. So now we'll move on to our patients. cerebellum. So again, we can see, oh, I apologize. Again, we can see the molecular layer here, the granular layer. Both of these form the cortex. And then we have the white matter layer within those. Zooming in again over just on this section, we look over here to the right image, we can see again molecular layer, granular layer, and then in between are those Purkinje cells pointed out by these arrows. Now, the interesting portion of this image, we can see this little section here. We start to see again these non-caseating granulomas, and this is within our patient's cerebellum. Again, we see giant cells like we saw within the pituitary granuloma, and then surrounding mononuclear cells or these lymphocytes. So these granulomas could be caused by diseases such as tuberculosis or some sort of fungal disease, potentially. We would need to biopsy these granulomas specifically to culture them in order to rule out any causes from culturable organisms. So now we'll look at a normal conjunctiva. So looking at this image, we can see the outer eyelid is marked by this blue arrow, and then we have the inner eyelid or the conjunctiva marked by this orange arrow here. There is a circularly oriented skeletal muscle that surrounds the eye. This is called the orbicularis oculi muscle, marked by the OO here. We would have to zoom in to see that on this slideshow, but there are skeletal muscle here in this area. There's also the tarsal plate marked by TP. Is this section here just beneath the orbicularis oculi muscle. And then within the tarsal plate, if we look at this section here, looking at the middle image, we can see these tarsal glands. And these tarsal glands are secreting sebaceous substances onto the eye itself in order to protect from any tears or the fluid covering the eye from evaporating. And then if we look at this top section, the more superior portion of the eyelid, we zoom in and we can see these Wolfring accessory lacrimal glands. And then looking more inferiorly, there is a junction that I will show you in the next image. But that junction, you start to see a difference in the epithelia between the outer eyelid and the conjunctiva. And then on the portion of the outer eyelid, we can zoom in here and we can see the presence of a hair follicle. Within that hair follicle, we also see the association of a sebaceous gland here. This is very similar to any other image that we would see of a skin slide that would have these hair follicles. Now we are going to look at the conjunctiva of our patient. So if we look at slide A here, this section here, again, we see the orbicularis oculi muscle. We also see the tarsal plate, which would span from about here to here. We can see an epithelial layer here and a different epithelial layer here. So this arrow is pointing to a junction between the two called the mucocutaneous junction. That's telling you the outer eyelid, which would be this epithelia here. And then we have the conjunctiva starting here on the left side of this arrow. And then also we see with the outer eyelid, the hair follicle, again, similar to the last image. Specifically, we can see that there are a lot of granulomas within all layers here of this section. Looking over at example B, this is a zoomed in image of the tarsal plate. So we can see these granulomas forming once again within the tarsal plate. There's an asterisk here just showing one of the granulomas, but we have a few here. Again, these granulomas have these multinucleated giant cells within them, similar to the cerebellum and the anterior pituitary, One interesting portion about this is that we don't have any lymphocytes surrounding these granulomas. So the granulomas within the patient's conjunctiva might explain some of the patient's symptoms that they're experiencing, such as the dry, itchy, and red eyes that they came in with. It is very interesting to see that we have these granulomas within a bunch of different organs thus far, and I'd love to hear what my other colleagues have to say about what their findings are. Thank you.
Hello, I'm Dr. Margaret Pierce, and I'm a cardiothoracic surgeon who has been asked to be a part of the mortality conference to help discover a patient's cause of death. I obtained my MD from Yale University, and I'm chief of the cardiothoracic surgery department at Duke University. I also received my master's of biomedical sciences from Duke University. Now, let's take a look at a histological slide of the heart. In figure 1, we're viewing a cross-section of the myocardium, which is the muscular tissue of the heart. In this portion of the heart, we expect to see cardiomyocytes, which are cardiac muscle cells. Cardiac muscle is striated, like skeletal muscle. However, they usually have a single centrally located nucleus, which lets us know we are looking at the heart. And this is what we see in figure 1. Also in figure 1, we see these blood vessels filled with red blood cells. Now in figure 2, we are viewing a longitudinal section of the myocardium. In this histological slide, we can see striations and intercalated discs, which are histological features of the heart. Figure 2b is just a closer look at the striations within the cardiac muscle cells. On histological examination of the patient's heart, we see a non-necrotizing granuloma that is composed of nodular lesions with mononuclear cells, fibroblasts, and multinucleated giant cells, which are pointed out by the arrow here. In figure 4, notice there's another granuloma pointed out by the arrow. Granulomas are usually compact, centrally localized collections of immune cells, comprising macrophages and encircled by lymphocytes. Granulomas most commonly form in the lungs and lymph nodes, but they can appear in virtually any organ and ultimately interfere with normal organ function. So, the presence of granulomas and giant multinucleated cells in the patient's histological slides are indicative of sarcoidosis and giant cell myocarditis. Let's take a closer look at some sarcoidosis cardiac muscle. So in figure 5, this is a histological slide from one of my patients who has cardiac sarcoidosis. The predominant histological finding in cardiac sarcoidosis is scar-like lesions with epithelioid granulomas throughout the myocardium. The granuloma shown here is well demarcated and associated with a mononuclear inflammatory infiltrate consisting of small lymphocytes. In this specimen, the surrounding myocytes that we see here are largely unaffected. So lastly, here's this histological slide from another one of my patients who had giant cell myocarditis. In giant cell myocarditis, we tend to see inflammatory infiltrates composed of multinucleated giant cells, frequent eosinophils, and mononuclear inflammatory cells. In figure 7, notice that we see the presence of the giant multinucleated cells indicated by these white arrows. So, sarcoidosis and giant cell myocarditis are pathologically similar, and attempts at pathological differentiation between the two remain very difficult. Therefore, further examination of the patient's body as a whole should be considered in order to identify an accurate diagnosis. Well, that's my take on it. Thank you.
Hello, everyone. This is Christina Yang. I am a urogynecologist and rheumatologist. I received my education at the University of Chapel Hill School of Medicine. Just like my colleagues, I received my Master's of Biomedical Sciences at Duke University, and I'm currently an attending physician at Duke University Hospital. And today we are going to talk about the histological findings of the bladder and of the skeletal muscle with a patient with sarcoidosis as well to look into slides in comparison. So to give you a review of the normal bladder, take note of here, this cross-sectional cut of a bladder. We're going to go inward towards the epithelial lining, the lumen. So right here, this is a zoom in version of the bladder. The epithelial lining of the bladder is the transitional epithelium, which is also known as the urothelium in the bladder specifically. Please take note of the varying shapes and sizes of the epithelial cells in this layer. This is what gives the transitional epithelium its characteristic. Also, if I did not note this, this is also known as the urothelium. And within the urothelium, you have these distinct cells on the most outer layer of the epithelial lining called the umbrella cells. Beyond the epithelial lining, you will see the lamina propria layer. This is a loose connective tissue layer. And beyond that here, you will see the muscularis externa, which is comprised of 3 layers of smooth muscle. They are typically arranged in a longitudinal, circumferential, and longitudinal order. But in this case of a cross-section of the bladder, this is the reverse in where you will see the circumferential, longitudinal, and then circumferential layer. Finally, when you go to the most outer layer of the bladder, you will see that there is either an aphytitia or serosa layer. Now, for a patient with sarcoidosis, you can see here that the bladder is very different than a normal bladder. Sarcoidosis is most noted for its granuloma sections, which is noted by the increased amount of immune cells acting up in the affected areas of the bladder. So in this case, you can see here that a very large portion of the bladder is infected and inflamed, as noted by these granulomas. For a patient with sarcoidosis, their bladder will be inflamed, and so therefore they will be clinically reporting hematuria, urgency, frequency, dysuria. Biologically, in a disease state in the bladder, you will see an increased secretion of ATP. This leads to the hyperactivity of those smooth muscles that we noted earlier, which causes frequent voiding. Now we move on to the skeletal muscle. Skeletal muscles are known for their striations in the peripheral nucleus. As seen in a longitudinal cut here, you can note the very clear distinct striations coming downward. It's a little bit difficult to see the nucleus, but we can clearly see that there is no sign of nucleus within the cells, and that there are little portions of them in the peripheral ends. However, in a cross-sectional cut of the skeletal muscle, you can take note of the striations, but you can also take note of their distinctive feature of the nucleus being on the peripheral ends. For a patient who has sarcoidosis, their skeletal muscles will also be reporting increased inflammation, known as granulomas. And so for a patient who has sarcoidosis affecting their skeletal muscle, you will clinically be seeing patients reporting fatigue and weakness around those areas. Musculoskeletal manifestations are seen up to 1/3 of patients who have sarcoidosis.
Here is a histological feature of a normal lymph node. Here you will see the lymph node label. It includes the lymphoid follicle, the cortex, the capsule, the medulla, the pericortex, and the subcapsular sinus. The cortex is made of B cells, T cells, and a medulla that includes macrophages and plasma cells. Here is a presentation of our patient's lymph nodes, which we feel to be an indicator of sarcoidosis. Here you will see the nodes are enlarged and very calcified. Here is a histological presentation of our patient's normal bone marrow. Here you will see the 3 zones, the endostyle, the intermediate, and the central. These zones include the immature myeloid, the erythroid, the maturing myeloid, and the megakaryocytes. And on the right side of the screen, you will see the erythroid island. Next is a presentation of a sarcoidosis bone marrow. Here you will see enlarged granulomas, and this patient also had a history of pulmonary sarcoidosis and presented with anemia and leukopenia.
Hello, everybody. My name is Dr. Weber, and I'll be presenting on the lung tissue and the skin tissue. This right here is a histological slide of a normal lung tissue. And more importantly, we see the respiratory zone, and we see how the alveoli, alveolar sacs right there, the alveolar ducts, and the two different kind of bronchioles. We see good evidence that the patient would have good adequate gas exchange here. However, during the patient presentation by Dr. Bailey, we noticed that this patient had two hilar nodules in the in her chest X-ray, as well as a paratracheal adenopathy, which are both signs indicative of sarcoidosis, which kind of helped start our differential diagnosing. The next thing I asked for was a lung biopsy, just to see if there's even more evidence. And as you can see, compared to the first slide, this does not look like a happy lung. We see a lot more evidence of inflammation, as well as immunological activity. If we get closer into it, we see evidence of nodules or granulomas. And you can see that here specifically, like a specific granuloma. We also are able to see giant cells, which again are cells that are common with intense immunological activity. And those giant cells are actually, again, not indicative 100% of sarcoidosis, but again, helps with our differential diagnosing. And kind of, we see granulomas like these, we kind of want to differentiate, are they caseating or non-caseating? Non-caseating means that there's no necrosis. So here there's good evidence of cellular activity, while here caseating, which means necrotizing, right there, we could see evidence of necrosis there. So for caseating granulomas, we would think this patient would most likely had tuberculosis. However, since this patient is non-caseating, as you can see, we are assuming that the patient is, again, helping. We're more likely to think that it's sarcoidosis. Again, and then we want to take a look at the patient's skin. So we saw some red blotchy skin. So we decided to do a skin biopsy on that. And in the skin biopsy, we noticed that there are 4 layers of the epidermis, right? So we have stratum basale, stratum spinosum, stratum granulosum, stratum corneum. And then we have the dermal papillae, and this is usually a lot more dense regular connective tissue. However, unfortunately here we see evidence of more granulomas and immunological activity. So again, this kind of helps our thought process that since sarcoidosis is a multi-organ response, this just kind of gave more evidence that we believe that our differential diagnosis is indeed sarcoidosis. And that is all I have. Thank you for listening.
Hi, I'm Dr. Meredith Griffin, as seen by my badge ID. I'm a hepatologist and a hematologist who has been asked to be part of this mortality conference panel to help discover the cause of death of a patient because I'm extremely bright and intelligent. I obtained my MD degree from Boston University, and I'm an attending physician at Duke University Hospital. I also received my Master's of Biomedical Sciences from the Duke University MBS program along with my fellow colleagues, as they will explain. So, we're going to learn about some liver and spleen samples. Let's start off with a liver. Here is my glorious intro slide and the gorgeous photo of myself and another introduction, but you should have been paying attention already to that. So our first slide here is a typical liver. As you can note here, it can be identified by the organization of liver parenchyma. Individual lobules are seen as lighter areas with darker edges at low magnification. The lobules have a roughly hexagonal structure with a central vein at its center and 6 portal triads at the periphery, but this is rarely seen in sections. The central vein is a large venule at the center of the lobule, hence the term central. The portal triads are at corners of each lobule and include hepatic arteries, a portal vein, bile duct, and lymphatic vessels. The hepatocytes are anastomosing plates that are 1 cell thick and radiate outward from the central vein. They are separated by sinusoidal capillaries and supported by reticular fibers. The bile ducts are lined by simple cuboidal epithelium. As in this section, you can see another bile duct, an endothelial cell lining the blood vessel, sinusoids, hepatocytes, bile caniculi for the bile to travel through, Kupffer cells, and spaces of Unessay. Here is an example of the tall columnar epithelium present in bile ducts. Another example of 2 slides stained differently. In this slide on the right is a sample from a not so healthy individual, but still pretty regular since the foamy hepatocytes are present, which is more present with people who have excessive fat or damage to the liver, either through alcoholism or other means. Bile caniculi are present here, sinusoids, and space of Unessay. They are separated by sinusoidal capillaries and supported by reticular fibers, also as present in this photo. The bile ducts are also lined here with simple cuboidal epithelium. The spaces between the hepatocytes and sinusoids are known as the spaces of Unessay, as presented throughout these slides. There are also Kupffer cells and stellate cells present. There is no presence of granulomas or infection, so this is a healthy specimen. Also, the evidence points to this histological specimen being the liver. We are now going to move on to our patient's liver. So here is a histological slide or slides taken from the patient's liver. It can be identified as the liver based on the same evidence discovered in the previous healthy specimens samples, such as portal triads, bile ducts, and lobules. The sections taken on these slides that are shown in these photographs have been zoomed in to focus on the diagnosis of this patient, so may not include portal triads and other identifying pieces of a liver. However, in the specimen, there is presence of granulomas leading to a diagnosis of granulomous hepatitis. Granulomas can be present here on the left, and on the right, they have arrows pointing to them. Granulomous hepatitis is presented as focal or multifocal aggregates of activated macrophages with epithelioid appearance, usually accompanied by lymphocytes and plasma cells. Now we are going to take a look at a typical spleen. The slide depicted demonstrates a typical healthy spleen as presented by the distinction of white pulp, as circled here, versus red pulp, as presented. The white pulp is composed of lymphatic tissue and appears basophilic due to the large number of nuclei. It contains splenic nodules, which have clusters of B lymphocytes located on central arterioles. These usually contain a germinal center of activated B lymphocytes. The white pulp also has a central arteriole with branches of trabecular arteries coated by periarterial lymphatic sheaths, or also known as PALs, and are adjacent to nodules. The PALs are cylindrical masses of mature T lymphocytes that surround central arterioles. The red pulp filters and degrades red blood cells, and it appears eosinophilic due to the large number of red blood cells. It contains splenic sinusoids or vascular spaces lined by specialized endothelial cells that filter red blood cells. There are also splenic cords or cords of Billroth, if you're more knowledgeable, like me, which are loose connective tissue that contains macrophages, plasma cells, and lymphocytes. The pulp arterioles are not surrounded by lymphocytes like central arterioles in white pulp. The spleen is encapsulated by a dense connective tissue called a capsule, hence encapsulated. The marginal zone is the area between the red and white pulp, and it is where macrophages, dendritic cells, and lymphocytes interact. So, as present here, you can see the cords of Billroth as these black lines, and the sinuses have been directed by these blue arrows, and they're the white spaces. There is a vein present on the right slide as well. Now we will go through the patient's spleen. It was noted that during collection of the deceased patient's spleen, there was splenomegaly, or if you're more knowledgeable like me, it's also known as enlarged spleen. On histological examination of the spleen, non-caseating granulomas consisting of highly differentiated mononuclear phagocytes and lymphocytes were depicted. Special staining for acid-fast bacilli and fungi was negative. The slides depict low and high power slides with multiple histocyte consisting follicles and absence of central necrosis or evidence of polynuclear neutrophils. So you can see granulomas present throughout these slides. More slides will be depicted here in a different stain. They are present throughout, and it is very hard to distinguish the difference between the red and the white pulp. So marginal zone is very hard to depict as well. Here it is very noticeable in the middle, a granulosoma. All of this evidence could be indicative of several different causes, but would need further evaluation of the patient as a whole, which is why we have gathered together as a team. So far, based on the gathered evidence from the spleen and the liver, it is possible this patient may have Ehrlichius, Wegener's granulomatosis, Crohn's disease, Churg-Strauss disease, Takayasu's arteritis, sarcoidosis, tuberculosis, histoplasmosis, hepatitis, or primary biliary cirrhosis. This conference has been formed to help determine the best diagnosis from all our determined differential diagnoses to help this family come to ease with their loss. Well, that's been Dr. Meredith Gray for you, the best of us, of course.
Hello, everyone. Thank you for coming into this conference. I am Dr. Bailey, and I serve as a hematologist and oncologist here at Duke Hospital. Since this is being recorded for the Duke medical students, can you all briefly introduce yourselves?
Hello, I am Dr. Shepard. That's Derek Shepard. I am a attending neurologist at the Cleveland Clinic, and I'm here with my colleagues. We're all from the Duke MBS program.
I'm Dr. Meredith Gray. I am a hepatologist and a hematologist, and I am a current attending at Duke University.
I am Dr. Christina Yang. I am a urogynecologist and rheumatologist at Duke University Hospital.
I am Dr. Maggie Pierce. I am a cardiothoracic surgeon at Duke University Hospital.
I am Dr. Weber, and I am a pulmonologist here at Duke University.
All righty, thank you all for that. We'll start with our patient presentation. The patient is a 21-year-old retired Olympic swimmer, and she presented in the ER with fatigue, night sweats, rashes on her skin, blurred vision, shortness of breath, and swollen lymph nodes. The patient soon went into cardiac arrest, and after the assessment started, due to the patient having enlarged and calcified lymph nodes, we were thinking that it may be an indicator of sarcoidosis. All right, Dr. Shepard, what are you thinking about this patient so far?
All right. Hello, everybody. Again, I'm Dr. Shepard. Thank you, Dr. Bailey, for that introduction. And so I was going to go through my differential diagnoses. I had a couple, but I'd like to hear what my colleagues have to say as well. One diagnosis I'd like to bring up to you guys is something called Cogan syndrome. And the reason that I'm coming up with this diagnosis is that we saw, if you looked at my lecture, we saw some ocular manifestations of granulomas. And so with Cogan's disease, it's a idiopathic inflammatory disease. And so I think that it could be explaining some of the symptoms that we were seeing that Dr. Bailey already presented to us, such as the red, itchy eyes and some vision loss as well. But I'd like to hear what else we have to say.
Okay, Dr. Pierce.
Yeah, so if you guys like watched my video, you see that I spoke briefly about, I believe that the patient either has cardiac sarcoidosis or giant cell myocarditis. So one of the indications a reason why I saw, why I believe the patient had cardiac sarcoidosis, I pointed out some granulomas that I saw in her histological slides, but I also saw some giant multinucleated cells. And so sarcoidosis and giant cell myocarditis are pathologically similar, and attempts at pathologically differentiating between them are very difficult. So I think I personally need some further examination of the patient's body as a whole, and look forward to hearing some of the other differentials to see if we can identify an accurate diagnosis.
Sounds good. What about you, Dr. Gray? What did you think about this case?
So since I examined both the spleen and the liver, I had a few different differential diagnoses. I did not come across sarcoidosis, but I thought of primary biliary cholangitis, Churg-Strauss syndrome, tuberculosis, and Takayusu disease. With primary biliary, the symptoms seem to line up with the patient having fatigue. She also had swelling of the spleen or splenomegaly, and granulomas were present both in the liver and the spleen. So it was possible she had failure of the liver, which would align with this disease. Also, Churg-Strauss syndrome was a possibility. There's also granulomas present with this disease. However, asthma is more common in hay fever and inflamed sinuses, which don't necessarily line up with what the symptoms we've heard, but weight loss and night sweats are common as well. But I'd like to hear more from our fellow colleagues.
You know, Dr. Gray, before you're done, I heard you brought up Takayasu disease, and I also had that on my differential. And the reason being is, I saw some inflammation of some of the blood vessels within the pituitary gland specifically. So I just wanted to put that out there. That was something that I also saw on the histopathological slides.
I agree with your diagnosis, and I think we should look further into that one.
All right, Dr. Yang and then Dr. Weber, what do you all think?
Slides from my histology findings have shown unremarkable findings for this patient and to having any issues. However, I wholeheartedly agree with Dr. Gray's analysis and in her findings.
Well, after reviewing everybody's presentation, I've come to the realization that almost everyone here is wrong, except me. I think Dr. Pierce was in the right ballpark. I do believe that it is indeed sarcoidosis. Looking at Cogan disease syndrome, obviously everybody knows that this the patients have vision difficulty, hearing loss, and dizziness, which was not consistent with our patient. So I still don't understand how Dr. Shepard actually ever got his MD. He maybe got it from like a cereal box, but whatever. I guess they give it to everybody these days. Again, Dr. Shepard again suggesting Takayasu's arteritis. Again, yes, it's a granulomatous large vessel vasculitis, but again, as based on all of our presentations, we see that this is a systemic granulomatous disease, not specifically to the large vessels. So again, that's kind of showing why Dr. Shepard, again, is an incompetent doctor.
I just don't know who keeps inviting you to these things, Dr. Weber. You just like to put us down. You were a terrible student when we were in the same class together. I don't even know why you're here.
Well, I'm actually here to, be right. I know you're not used to that. That's okay. But
I'd like to hear how you came up with sarcoidosis, being a pulmonologist.
well, again, since I am the best, simply. So obviously, I mean, it's kind of obvious to anyone who has actually got their MD, Dr. Shepard, that this is sarcoidosis, right? Because of a couple things. First, if you look at the chest x-ray, you notice that a lot of infiltrate is there, kind of similar to a restrictive pulmonary disease, which would be one dominant one would be sarcoidosis. We also see that the granuloma itself is non-caseating, so there's no necrosis, which again is more consistent with sarcoidosis, as well as, again, the bilateral hilar nodes. They're, again, pretty simple sarcoidosis. So essentially, like I said, Dr. Shepard, someone should take away your license.
But Dr. Weber, I see all the alcohol in your background, and I know that you enjoy some alcohol every once in a while. Have you had your drink today? You sound like you're a little drunk right now.
Dr. Shepard, that was a little out of line, but
I'm sorry, Dr.
Okay,
Gray.
Dr. Shepard obviously knows he will never be as good as me, and he needs to come and try to point out any possible thing he can.
Richard, that's enough. That's enough, Richard.
Wow.
It just drives me insane.
Dr. Weber, let's get back to the main point here. Now, I've got one question for you. How do you know this isn't something like tuberculosis?
So again, as we learned in medical school, but tuberculosis, it would have caseating granulomas. So you'd see a lot more necrosis in the granulomas themselves. But if you again looked at the pulmonary histology, you could obviously see that there's all non-caseating.
I can see where Dr. Weber's coming from with it being sarcoidosis.
I guess I also see the same. I hate to admit it.
Yes, it was definitely very visible in my in the cardiac muscle, and so I definitely agree with Dr. Weber in diagnosing the patient with sarcoidosis.
Dr. Yang. Oh, I'm sorry. Dr. Yang, do you have anything else to add?
I guess I'll agree with everything everyone is saying, but it's for the sake of going back to my surgery. I'm a little bit behind right now and they need me.
Okay. Well, thank you all for coming. I'm sorry that Dr. Weber and Dr. Shepard got into an argument, but hopefully you all will make up after this.
It was Dr. Shepard's fault.
Okay, Dr. Weber. Let's remember that the Duke students are watching us. So thank you all for coming to this conference, and we will reconvene later.